we have a team of surgeons. They will conduct this workshop during these 4 Saturdays. First of all, I wanted to thank them. They are voluntarily joining to conduct this workshop. So I will be there time to time, sharing our experience, my experience, and we can discuss. Is there any? Then we have Dr. Ranga Perera, who is a consultant oncological surgeon. And he is the Dean of the Faculty of Allied Health Sciences, Surgeon, Kotalavala Defense University. He's a senior lecturer. He is the Vice President of the College of Palliative Medicine of Sri Lanka. And he is very, in oncosurgical discipline, they are doing, many cases. He's a very good surgeon at Sir John Kotalavala Defense University. So Ranga Perera will talk to you. There is a little slight change of the agenda. Today, Dr. Ranga is supposed to talk, but we have changed it. Our next speaker will talk. I think next one is Dr. Thusitha Kahaduwa. So he will talk to you today. So his lecture will be the first lecture. Then Ranga will take over from the next week. Actually, Dr. Thusitha is the first batch diplomate in palliative care. You all know in Sri Lanka, we have a diploma in palliative medicine, started few years back. He's one of the first member who obtained the diploma in palliative medicine, and he's he is doing MSc in community medicine also. And Dr. Thusitha is a practical palliative care and wound care practitioner. He is having a vast experience about how to treat, how you will get to know his expertise. He will share his expertise with you all. Okay, the next one. Next one is Dr. Tushan Gunaratna. Actually, Tushan is a consultant vascular surgeon and a senior lecturer, Faculty of Medicine, University of Colombo. He's practicing in NHSL. Tushan is attached to the Prof unit, and he's a good vascular surgeon, and his lectures are really amazing. Once he did a wonderful lecture series for our colleagues also. So Tushan will give his expertise in this workshop. Then Dr. Kitsiri Senanayaka, again our brilliant surgeon from Rajarata University. He is attached to the teaching hospital Anuradhapura. Kitsiri is a general surgeon, but with a special interest of endocrine surgery. So Dr. Kitsiri again practicing, the very vast area, and his expertise also will contribute a lot to this workshop. Then we have Dr. Hilary Fernando. So he is a consultant urological surgeon, presently at District General Hospital, Monaragala. They all are council members of the College of Palliative Medicine. So Hilary is having a vast experience in robotic surgeries and especially the prostate cancers, advanced urological pathologies. So he's practicing, he's having a good practice. So Hilary also will contribute as a panelist. So this is our team, and I welcome Dr. Janaki Vidhana Patirana, our president-elect. Madam is the director of from the Ministry of Health, and we have Dr. Kumudu Veerakon, who is the senior registrar, our secretary, senior registrar in community medicine, secretary of the College of Palliative Medicine, Sri Lanka. So actually, this is the small introduction of the lecture panel. And I welcome all of you to join with our college, because every month we have a webinar series. And in October, in September, we will have our annual academic sessions. Actually, the palliative medicine, the era of palliative medicine is not yet developed in a full capacity. So there are immense opportunities to do research work and present it and many things. And actually, this is the only college who has the international accredited journal. We are affiliating with many international universities, especially with Brazilian Faculty of Medicine. So we have a joint international journal. So you all can publish your articles, research articles on that journal as well. It's an international publication then. So there are many opportunities when you all are joined with us. And this is the only college still the medical officers can join. So after this lecture series, we will send relevant information to you all, whoever wish to join with us. Actually, now all of you we have created a WhatsApp group with all the people, because for two reasons. One is to get to know each other, and when you are finishing this wound care course, you all can actually practice. So you can do a good practice, and you can treat your patients, because with the knowledge that you are going to gain from this workshop, you all can actually practice this. Then if you have any doubt, any cases, this group will be a opportunity to discuss about your group, about your cases as well. This is one opportunity. And the second one, college is getting opportunity to reach you all individually, to send the monthly webinar series about our academic sessions, about the news. So if you all are interested in palliative medicine, so you all can join, and you can enjoy the college time also. So anyway, I think I will open the floor. I'll ask our Madam Dr. Janaki Vidanapatirana to talk at least a few words in this occasion. So over to you, Madam.
Thank you very much, Dr. Samadhi. Actually, I am busy with accepting people. Still, they are trying to log in. Some of them are not managed to rename. Sorry about that. So, dear participants, we all, on behalf of the college, all you are welcome for this very special, very important course. This is a certificate course. I think most of the things Professor Samadhi has explained you without taking much time. So we can start the session, because some are still waiting. I am trying to help them. Over to you, Dr. Samadhi.
Thank you so much. So Madam will take over from next year. So she is our president-elect. Now I will give the floor to Dr. Thusitha Kahaduwa, who is the pioneer in this wound care business, and he is actually the coordinator, and he will explain you first about this course, and then Dr. Thusitha can continue your lecture today, because Dr. Ranga will do the next week, I suppose. And another thing, this everything will be recorded, and we are posting this recorded thing in our YouTube channel. We will inform you how to get that thing, and you all can get the recordings through our YouTube channel. Thank you. Dr. Thusitha Kahaduwa, over to you.
Thank you, Professor Samadhi, and Janaki Madam as well. Very good evening to you all. now I will briefly explain what we are going to do for the next four weeks. Before that, there are about 16 people in the waiting room, and I think there are quite a number of people already have joined. I don't know whether this can be sorted out. Anyway, we will continue, no? Prof. Samadhi, shall I continue without waiting for these 16 people, no?
I think yes, because
Yeah,
now
okay.
we can see more than two-thirds, actually 4/5 of people has joined, but
Yeah.
there are some difficulties for others. Maybe they are not following instructions. So I'm very particular about those things. I think you can continue. Anyway, we
Sure.
have a recording. I am still trying to help them, and they are not listening to this. That's the problem. Okay, you can continue.
Okay, thank you very much. So now what we are going to do for the next 4 weeks will be
Yeah, Dr. Thusitha. Yeah, Dr. Thusitha, I think some connection problem. Anyway, now Dr. Kumudu, can you share the agenda? Dr. Kumudu? Yeah. Yes. Thank you. Now today, as I mentioned, Dr. Rangapera will not talk to you. He will talk to you next week about the wound biology. His topic will be the wound biology, but today Thusitha will talk to you about, can you roll it up, Kumudu? Yeah, Thusitha is going to talk today about wound disruption. So he will talk about wound disruption now. Then Dr. Tushan Gunaratna will talk about wound bed preparation. So this is very important. And Dr. Kitsiri, the same day, will talk about dressing selections. It's also really, really important because now we see most of the wounds, actually, most of the wounds, due to this particular reason, the dressing selection, it's not getting healed. And now wound is a business, actually. People are living on wounds sometimes. And unfortunately, actually, this is a comment, and you all must understand this. Unfortunately, our doctors are not very keen on wound management. All the nurses, most of the nurses, and you know, there are very famous centers. The nurses, nursing officers are running about this wound management. So we have to, look into this problem very seriously. Not like, and we have to take it because we have all the, right and the knowledge, everything. So that is why we wanted to conduct this workshop actually. So Kitsiri will talk about dressing selection. Then Dr. Tushan is going to talk about management of bed sores. Management of bed sores. Because why we put this thing bed sore? Because in palliative care especially, we are dealing with bed sores, and with geriatric practice also, bed sores are really a problem. And if you know how to identify, how to diagnose very, very primary stages, and how to treat it, how to take care of bed sores, it's not a deal actually. We can nicely manage it. So that is why we put this bed sores thing. Actually, it's a full course about the bed sores, but we are going to discuss about bed sores in this lecture series as well.
Prof. Samadhi, I'm back. Some the technical problem, I dropped off. I think you have to give me the co-host.
Then sure. And Dr. Hillary, time to time, he will be join as a panelist when we are discussing about many things. His expertise also will be there. So now Thusitha can start your presentation now. Thank you. Now you are co-host, Thusitha.
Yeah, okay, got it. Okay, many people were asking what is this assignment is about. So that is the main problem is what the assessment is. No, so let's clear the whole clear that up and then proceed with the discussion. No, I think Professor Samadhi, did we share this with the participants? So do I have to share it?
Everything is with them now. Everything, but
so the assignment was shared, no? So that's not a big thing. You just have to. It's all self-explanatory. You just have to explain a case. Take a case that you have done recently, and describe how you applied or have you analyzed your case with the concepts that we are discussing in the course. So I have put down a list of 10. Just fill in the blanks on this, and please follow the instructions on the spacing and page numbers and what the type of letters to use and all that. And if you are using tables and pictures, they should be numbered, and the source should be credited. So it's not that we are going to submit it into Turnitin or whatever. Just you can do a little bit of copy and paste. But the thing is, it has to be a sound and presentable assignment at the end of this thing, because now you are getting a certificate from a professional body. So there should be a certain quality in the final submission. So it's not don't take it very seriously. We just need about 1,500 words. So you can go on if you want to. Bullet points are accepted. So just a quick introduction to the case, and then how you analyze the wound biology, and how you did the wound bed preparation according to the concept that we discussed, whether you used it or why didn't you use it, and that's sort of a small discussion. then how you did the design selection, whether it's appropriate or why it's not appropriate, according to again to what we are discussing here, and the overall management of the patient, and what is the outcome as of now when you are writing the report, and what at the end, what measures you took for wound prevention. And I mean, if you are, say, for example, if you are treating one leg, say there's a foot wound, there's another foot as well. So you have to do wound prevention in that. And if, quite obviously, once you have healed the wound, you have to prevent further wounding. So those things have to be discussed, and that will be discussed in the during these four weeks as well. And then what are the barriers and difficulties you encountered, and a brief discussion of what how you actually analyze this using the knowledge gained and all that. And the recommendations actually it can be sort of hairy and audacious, that you can say that this should happen for the betterment of all this, and these are the things that we are lacking and all that. So that's not a serious issue. So just take it very lightly, but do it in a very presentable way. So it's everything is, I have compiled it in such a manner. Just have to put your student the name that you registered, and that this name will appear in your certificate, and the student number that you gain from Prof. Samadhi. So that's that. Now we shall get into the discussion. So the idea of this is not a lecture. I won't call it a lecture. This is I'm trying to discuss the essence of wound care, cover most of the topics in very superficially. These will be discussed in little bit of depth, because this is a basic course in the coming lectures. So I'm just touching on everything, and the main thing what I want to do here is to challenge what you are doing already. So that's why the name Disrupt. So it's not about wound disruption or disrupted wounds. So this is to disrupt what you think already. So why you should listen to me? Obviously. So these are my credentials. I have been I have invented device to detect diabetic foot damages in 2015. I got a gold medal for that in Geneva, and then I was the one who designed the Nirogi shoe, which is all around the country now. Nirogi shoe and the Beta shoe for wound prevention. That is done by DSI and D Samsons. So so I have done a lot of research, and I have presented in a number of countries, and I'm an inventor. I have about 10 pending patents, and quite a number of offered patents, including one for negative pressure wound therapy machine made in Sri Lanka. So that's about me. So you can find me in YouTube. Most of the lectures are there in my YouTube. This is Dr. Thusitha Kahaduwa. Just type Thusitha Kahaduwa in YouTube and it will come. And I have my Facebook page. Just you can search Dr. Thusitha Kahaduwa, then it will direct you to my Facebook page, which has a lot of research articles from podiatry to wound care and all that, and some work I have done, and I just wanted to show some scientific and easy to do stuff around the bedside. So it's not a promotional site. It's sort of informative. So what we are going to talk today is about I've already told you all that I'm going to challenge you all about what you already think. So there are 97 participants. I would like you all to when I question you all, you just unmute the mic and you can just answer, and then please be kind enough to shut it down. So otherwise others will get distracted now. So the first thing is that there is a question whether antibiotics should be used in wound care. This is a question. We'll have a discussion.
If it is infected, yes, we have to use antibiotics, but not for all. In umbrella term, we should not use antibiotics.
Sure. Yeah. Good. So infected. So if the if the local infection, would you use it?
Also depends on the
yes.
patient's condition, right? If they're not diabetic and if they're healthy young individuals, I don't think if it's a smaller wound, we need high strength antibiotics.
Right. But you say you do a culture. So the patient is apparently not septic, walking and talking and eating and all that. So quite a large wound. Do a culture. I have seen this happening. Even a bed sore, say, sensitive to piptas, imipenem and all that. Would you use it?
If it's a systemic infection, only use.
No in systemic infection, but it's a huge wound though.
No, I won't use antibiotics because anyway cultures will
If
become
it's
positive.
say if there's no systemic infection, but there's a bug there, what can it be? What does it mean? There are no systemic or local signs of infection, but when you culture, there's a bug.
It's a contaminated wounds.
Sampling error?
Actually, most wounds are colonized. Almost all chronic wounds are colonized. So that's a colonization. So colonization, we don't bother about colonization until it's the healing process is happening. There's a point where the healing process is disturbed, called critical colonization. That is where we should act. Critical colonization can lead to local sepsis and systemic sepsis. But critical colonization doesn't need antibiotics. You need local care, local antiseptics, antiseptic dressings, and sort of thing. So the next question is, are expensive dressings better?
Yes.
How so?
They have their inherited properties. Some absorb excess discharges, and some makes dry wound wet. So these dressings are better than normal dressings.
So, as you said, some of them absorb, some of them discharge, some of them give, that sort of thing. So they are they actually better than simpler dressings for all wounds?
Not for all wounds. For selected wounds, they are better.
Exactly. For selected wounds, in the sense, they are now, when you do a research and produce something, it's very targeted. No, very targeted. The dressing is very targeted. So then there are quite a few indications. So those are better for those indications. Not essentially better. So we'll discuss. I will come to that later. So for that particular indication, if it's there, that is better than a simpler dressing. So anyway, did you get what I'm trying to say? We will come to that later. So can there be one advanced dressing that suits all wounds?
I won't think so.
So the same logic that when you go do advanced research, those are rather targeted and deep. So the number of indications also go down with it. So the next question is, if there's no progression, should we change to a better dressing?
Yes.
To another dressing?
Yes.
Would that help? Just changing dressings from 500 rupee to 1,000 to 5,000 to 50,000. I mean, there are 50,000 rupee dressings. The wax are like 62,000 to 50,000. Now it's dropping. Still, there are 50,000 rupee wax dressings. So that's what you should do.
Before changing the dressing, we should find the cause for poor healing. And if underlying precipitation factor lies very close vein, so
True.
poor blood supply.
Yeah. So, are home dressings bad? What do you think? It's whether we should advise on home dressings, whether we should discourage home dressings. I mean, if the home dressings are very bad for the pocket, if you are running a wound boutique, there are quite a number of wound boutiques appearing. It's not good business.
That depends on the wound, sir.
It reduces hospitalized acquired infections.
Yeah. That sort of thing. Yeah, we will discuss in the coming this thing. So the rest of the questions are actually say, if you heal this one, another one will come somewhere else. Is that true? Can there be another one? Will there be another one? Okay, that will also come again. So in the presentation. So is there any karma in wound healing? Do you all believe in karma? Oh, no, that's not a good question to discuss at this hour of the day and during a lecture. Anyway, is there any part of karma involved in wound healing? People, your patients may be saying so. It's a karma, and I have to go through this. Otherwise, I'll have something else like. Any part of that? Because I have seen some doctors also, if they are treating wounds, they put up a Buddha statue and all that, and they become a little bit religious that they are doing something against the will of some other organisms, like. So obviously the next one is Heladeshiya method, whether the like the Dhammika Paniya, and there are magic treatments for wounds. They appear and go and that sort of things. So so those are a few questions I thought of. Any other questions that there are 99 participants. Are there any other questions that I should add to this list? Come on, it's a discussion. Is there anything that you can add? Okay, so this is what I want to just in a nutshell discuss today. So simply, what is a wound? What are the types of wounds? And basic physiology of wound healing. I'm not going to actually discuss the physiology of healing and all that because Dr. Angapera will be doing it on the next Saturday, and types of wound, all that as well. So again, little bit on causality. That's what I'm going to discuss, and the myths. And actually, we have done that already. And managing the patient with a wound bed preparation, what's an ideal dressing, how to do dressing selection, touching on that because there's a whole lecture on it. And what are the red alerts, when to refer, and little bit on wound prevention. There's another lecture on wound prevention as well. So this is sort of covers the whole thing very superficially. So just for you all to have an idea and a discussion. So to start off, a wound. So what is a wound? What is a wound? Can anyone tell what is a wound in just very simple terms?
The loss of skin integrity.
Cannot hear properly.
Break in skin barrier.
Yeah, any break in the skin. So since we are talking about skin wounds, there are other wounds as well in the epithelium. And somebody is. Can you mute this? Yeah. Okay. So this wound. What would happen to this wound? What I'm asking is what would happen to this wound if everything is at their best, nothing is going wrong. If everything is going perfectly well, what would happen?
Will heal with the scar.
No, two people are talking at once. What did you say?
Overgranulation.
Overgranulation. Why, if everything is perfect, why should there be overgranulation?
It will heal by fibrosis.
Heal by fibrosis. Secondary intention, yeah, fibrosis happens, but is healed by epithelialization, no? So I mean, the wound will simply heal. If everything is perfect, it will heal. So even few things are imperfect, what would happen?
It become a chronic wound.
No, quite a few things imperfect. I suggest it will still heal. I will tell you the reasons later. So moving on. So what would happen to this wound is actually about any chronic wound it came to life as a acute wound. So this is acute wound healing. So these are the steps that any wound should go through. So they are not the chronic wounds don't go through another set of healing processes. This is the wound healing process. So once the wound healing happens, you all may remember all this from the medical student days to if you have done postgraduate there as well. So there will be a blood clot formation, and there will be inflammation. Up to about day 6, the blood clot will be traversed by neutrophils, macrophages, and all that, inflammatory cells. So those are really oxygen dependent processes. These cells get activated with oxygen. They need a lot of oxygen to come to that area. So that is something that that will come up later in my lectures, as well as in Dr. Anga's lectures as well. Because you know what happens when there are no blood or oxygen supply is reduced. So inflammation and then proliferation. So proliferation, there are so many things happening at once. You know, the blood vessels, newly blood vessels formation. You know, there are so many signaling processes, so many autocrine sort of hormones, so many molecules signaling to cells, and it's very complex, very complex. That's what I wanted to highlight. Even the inflammatory process, hemostasis, all that is very complex. You may remember the how complex the clotting process is, no? So see, all these are very complex processes. Then ultimately maturation, the collagen, change of collagen types, and forming a rigid scar that much smaller than the original wound. So these so many things involved, so many cell types, so many signaling processes. So these are very complex process, evolved over millions of years. So this whole process is there to heal the wounds. The body is geared to heal. So many millions of years we have evolved ourselves to heal. So that's why wounds will heal. Wounds will heal. Wounds, even if you treat them badly, I suggest about 90% of wounds will heal. Even if you put the worst dressing, if you do the worst thing possible, even if you don't treat at all. Would you agree? Would you agree on that? Because so many millions of years, so many processes, very complex. Even if one or two things go wrong, I mean, quite simple processes in the sub processes go wrong, I don't think it's going to make a difference. I mean, in the clinical practice, if you practice scientific wound care, you know that the wounds heal. Wounds are supposed to heal. So that's the point. So the body is biased towards healing. So what puts the balance towards non-healing? Those are the things that we have to look for. Those are the barriers. So those are the things that we have to correct. So you see, this millions of years of evolution has given us this process. You see this huge wound, and ultimately you can hardly see. So this is natural healing. So my point is that if you 90% of wounds, even more than 90% of wounds, will just heal. So then we come to the point where our home dressing is good. They know the basics. I suggest home dressings are good. So what would happen? How does a chronic wound happen occur? Where is it stuck in this process? This is the process even a chronic wound will go through. Any idea where it gets stuck? Okay, let's go through the other ones as well and then come back. This is what I wanted to tell you. See, we have evolved to heal. I'm not to sit down and listen to Zoom lectures by Thusitha Kahaduwa. So anyway, this is the product of that natural process. See, this huge wound came as an abscess and finally giving rise to this tiny bit of scar. So this has matured, not matured fully. This is after about 2 months or so. So the maturation process takes about 1 or 2 years probably. The final product will be much smaller than this. So only a few corrections were needed in this. So this is what the body is capable of. So what are we doing? Why should we bother then? If the body is taking care of it all, why should we bother? Is it because we can have a now since the body is doing everything, we can have a boutique and we can pay the civil fellows 500 rupees per patient and spread the word that we are doing wound care and get a lot of patients. Since the body is anyway doing it, we can do anything and the wounds heal. So that Mahatya is very good at wound healing. Who's actually doing the work? The body. So that's what we should do. So 90% doesn't need us. So I know there are a lot of people doing not a lot of doctors, nurses and all. So they are doing these wound boutiques. I suggest most of those wounds that heal in those boutiques, they would have healed anyway if the patients treated themselves. You can check it out. So, as I said, the body is in a balance. Not actually a balance. The body is in a bias towards healing. So, what makes it unbalanced, and what does push the body towards not healing? So these are the barriers, and clinical barriers. I think most of you all must have heard of these clinical barriers. poor tissue perfusion, necrotic tissue, high bacterial count, edema, exudate, too much exudate, skin problems, malnutrition, dehydration, other systemic conditions that doesn't allow healing, and like psychological factors can be there, and or even altered mood, inability of self-care, all that can. But many people don't talk about these educational and professional and organizational barriers to healing. So you should think about these. See, the traditional knowledge, I will put Ida soap, that's it. Somebody has told Ida soap is good, and I put Ida soap to everything. So that is happening in many other hospital clinics. Nurses are putting Ida soap, or some other people are Acticode to everything. So that sort of inappropriate training and sort of traditional ritualistic practice, and most importantly, lack of understanding of research process. So when a marketeer, drug rep, brings you a dressing, give a moment. Professor Samadhi, one Anjula Senanayaka is waiting in the room. Shouldn't we admit him? Or...
Actually, I am asking from him through the WhatsApp messages regarding his registration number. He is not giving.
Okay, and okay. Then
Yeah.
can sort it out now. So, coming back to the discussion, see, even say when a drug rep brings you a dressing, you should be able to you should be able to appreciate the research process. You have to understand whether it's done in a proper manner, whether the presentation is correct, whether the graphs are correct, whether the data is actually feasible. I mean, 100% positive results are false, bogus results. So, I mean, you should have the basic idea of what the research process is, and a lot of poor quality research and biased research. And these days, actually, information overload. A lot of research and a lot of information going around in social networks and all that. So even in our scientific forums as well, a lot of information, can't sort out what's what. So all that should be, all those are barriers to healing. Barriers to healing of your patient's wound. So, and some people have negative attitudes to evidence-based practice, mostly these Ayurvedic fellows. They say our drugs work. You don't need evidence, any evidence. You don't have to do research. It works. So that should not be the practice that we as allopathy practitioners do. So, and professional and organizational problems. So there are no consensus of whether to use a simple dressing and then escalate this. There are dressing ladder, like the pain ladder and the antibiotic ladder. So, and professional rivalries, and you see instability of health services and lack of resources. So that has affected us now. So all those are barriers to healing. And even if we had all the resources, even if we are very stable, what about lack of focus on wound management? So that has been the case all these years up to 2020 until we were hit by the COVID and the actual colors of the country and the economy was showing itself. Before that, we were actually working in a sort of a posh environment. We had most of the things, but we had no focus on wound management and how to develop it and all. So just remember, I'm just trying to challenge your usual understanding. So here now, you see the process very complex, evolved over millions of years, and it's biased towards healing. The wounds heal, and then how? See, we have a big list of barriers to healing. And when we are presented with a chronic wound, what should we do? We should find the cause rather than changing dressings from 100 rupee dressing to the 500 rupee dressings to 1000 rupee dressings to the 50,000 rupee dressing. It's not going to work. You have to find the cause and treat it. This is what I call causality in wound healing. හේතුඵලවාදය තුවාල හොඳ කරන එකේ හේතුඵලවාදය. Causality in wound healing. Find the cause, treat the cause. If you have found the cause, if you are capable of correcting the cause, you have to have a lot of knowledge and analytical skill to find the cause, and that is a skill itself. And then you have to treat the cause. So that is another skill that you have to develop. So if you have done both of these things, does the dressing matter? Unless if it's part of your treatment. Do you need expensive dressings? I'm not getting any answers. Just say yes. I'm happy, you're happy then.
For selected wounds, there is expensive dressings will needed, but not for all the wounds.
Oh, what I suggest is if you have found the cause and corrected it. In my practice, actually, I use very simple dressings because most of the wounds, the cause is something else. The chronicity, the cause of chronicity is something else. And even if it's say the chronic wounds doesn't come with overwhelming sepsis mostly. There are chronic patients who walk and talk and eat. And mostly the problem is the chronic fibrosis and the biofilm. Does the biofilm, can you destroy the biofilm with all those fancy dressings? I don't think so. There are only quite a few dressings that will act on biofilm. That is also for about a few microns. So you have to find other ways and methods to deal with it if your cause is the biofilm. So all the rest is something else. You have corrected that. You just need a very simple dressing that does what needs to be done. What needs to be done, it will come later. Actually, it will be discussed in depth in the coming weeks as well. So the other point I want to make is, so a wound does not come to you. When you see a wound, it's not the wound, no. You should treat the patient. It should not be like I should not name the ward and all in a particular ward in NHSL where I also did my internship. So we were supposed to dress these anal problems, the fissures and all, and there's so much work that that interns don't have time to look at their faces, and they just come and they show their that the backside, and we distance it. And when the patients see us, they know this is Dr. So and so. But when we see patient's face, I mean, we don't see the other side when you're walking in the corridor. No, we don't. We actually don't know them. But if they show the backside, we will know them. This is Piyadas. So it should not be like that. You should know your patient, and you should treat your patient. So the patients have a lot of other medical issues, psychological issues, social issues, economical issues, spiritual issues, and all those things. So that is part of wound care, not part of wound care. That is wound care. Should do a holistic approach. You should take the patient as a whole. It's not putting a dressing and sending him off. There are so many things to do. Probably your main cause for chronicity is one of these issues. Am I making any sense?
Yes.
Yes.
Thank you. So
Yes.
So the medical issues, you should look into the comorbidities.
Yeah, Kitsiri, now Thusitha is having some, I think, some technical problem.
Mm-hmm.
Yeah. Can you just, can you just share one of your experiences with them?
Yeah. Okay. Hope everybody can hear me.
Yes, we can hear you.
Okay. Actually, I am accidentally joined the meeting today because I was in on call and was in commitments. Anyway, happy to join and share a few experience with you all. Basically, as Dr. Thusitha said, managing the chronic wound, the main thing is to find out the cause. For example, if there's a venous ulcer, I have seen many places, especially non-medical people, they continuously put in medications, and it causes a huge problem actually. So as medical people, we need to attend to them and find the cause and treat. And recently, I received several malignant ulcers, which have been treated for months and months without taking a biopsy. So if there's no healing, please get a biopsy from the edge, and then we can find a cause. And further, especially in Anuradhapura and probably the other areas in Sri Lanka, the leishmaniasis is a very common thing. So if there's a non-healing thing, please suspect that thing as well. So what I do in my wound care practices is that actually I will be discussing this thing when I come to do my lecture in next, or probably the week after. So I'll be discussing the same thing. So when I see a wound, what I see is first thing is I see whether this wound is granulated or slough, or what is the percentage of slough to granulation, that is the yellow area to red area. So what kind of percentage, whether the wound is full with granulation or filled with granulation 100%, or it is patchy sloughish areas, or so basically the percentage of granulation to slough. That is the first thing that I see in a wound, a chronic wound, right? No, this is not acute wound. Management acute wound is totally different, as you all know. And the second thing I am going to see is the amount of fluid in the wound, that is the moisture. There are wounds which are dry and there are wounds which are very moist. So depending on the moisture content, the management is totally different. So you need to see whether the wound is sloughy, moist, sloughy, dry, moist, granulated, and there's no such called dry granulated. So those things you need to check, and each and every wound, the percentage of this mixture is different. So so as soon as you see, you have to get these point. Actually, this thing comes with your experience. When you have to see wounds, hundreds of wounds, and classify them in from your mind, whether these are granulated, whether these are sloughy, what is the percentage, is it a moist, what is the percentage of moisture, and things like that. So these two things are very, very important when you look at a chronic wound. It's actually basically the most important thing, I would say. Thusitha, when you come back to, please let me know. Hello.
Yeah, I am back. I didn't
Okay,
actually
please
know I
continue.
was out. I was just
Okay.
continuing. Yeah, I can't remember where. I don't know where I actually I was dropped out. Did can someone tell me whether you saw this and whether you heard me talking
Yes,
about
we
this?
did. No, that one was not done.
So
This one was done. This one was done. Not done.
medical courses, sir?
This one?
Yes, sir.
This
You
one.
just started and then it long
It
dropped,
just went
sir.
off. Yeah. Okay. Dr. Kisiri, can I continue now?
Yes, please. Sorry, actually, since your
Thank
absence,
you very
actually,
much for covering up. I don't know what happened. I was seeing this thing and the screen was working. I was just continuing to talk. So anyway, very sorry about the technical difficulty. You all can hear me now, no? You all can see this also.
Yes.
Yes. Okay, thank you. So I was just talking about whether you should look into comorbidities and nutrition. Of course, you should look into the proteins and other say zinc and other necessities, micronutrients as well, and so all that should be corrected to get optimal wound healing. So most of these patients are depressed. Say, I mean, just imagine having a chronic wound and it will never heal. It doesn't go away. It's stinky. It's very depressing. So these people are very depressed and they are very anxious as well. So what should we do for this? Your approach to these patients should be very gentle. I mean, I have seen people they blackguard these patients for not doing what they are asked to do and all that. So that doesn't work. That's not really good. We should appreciate that they are depressed, they are anxious, they have other problems. So should be very gentle. The dressing the wound dressing process is anyway, it's an agony. It's very painful and all. So at least we should try to give them some psychological the whole process we should try to make it a pleasant experience. So and they have a lot of social problems as well, and we are doctors. We actually we advise them on what's been taught to us in textbooks. So we should look into our patients, the day-to-day lives and their social background and all that, and we should advise them on what they can do. We should look whether they have help and can they travel, and how practical are clinic visits, the routine clinic visits, the frequent clinic visits, how practical are they? And all this should be looked into, and we should have a set of advices that suits each and every not to each and every case for that particular person. For that, actually, we have to have a good discussion. Takes a lot of time. Actually, scientific good wound care is not it's not a sort of a cash cow money making mechanism. It's actually a loss. If you are a GP, you can actually see about 10 patients in the time that you spend on one case of wounds. So is that right? Is that correct? It's very time consuming. The dressing process, as well as we have to if we have to interact with the patients a lot. And of course, in this current Sri Lankan context, very importantly, the economical aspects. Whether what we are prescribing them is affordable. And most of, say, a patient comes to you at 4:30, and you are charging, say, let's say just, for example, 1,000 rupees. And for the dressing, he spends around 1,500 rupees, let's say. So is that the expense? Actually not. He has to pay about 2,500 rupees for traveling for the three-wheeler. The three-wheel fellow earns more than you. And someone has to take the patient to you. The patient cannot work that particular day, especially when they are going to the government clinics. You say every other day dressings. Say every other day he cannot work. I mean, there are no jobs that are offered to work every other day. So he basically loses the job, and the country loses an able body to produce. So losses are everywhere. And if somebody is taking the patient in to the clinic, that person also loses a job, and he cannot work, and all those are lost to national productivity. So that's why you should look into recovery. So recovery versus rehabilitation. So we are masters. We are doctors. We are masters of rehabilitation. Rehabilitation is getting the patient to do what we want them to do. Recovery is a little different. Recovery is we are facilitating what they want to do and what they usually do. When a chronic, when a patient with a chronic wound comes, you should, as soon as possible, recover them to their normalcy, their normal job. If that person is doing say a boutique or a shop, that sort of thing, you should put the dressing in such a manner that he can work. He start working, and you should ask about his usual day-to-day activities, and you can advise on that as well. So you should recover them. Is that clear? That is something I wanted to emphasize today. That clear? Am I making any sense?
Yes, yes.
Yes, sir.
Clear, no? That you should
Yes,
always
sir.
try to recover. You should. That's why this discussion, the good patient relationship, and you should spend a lot of time. I mean, anyway, when you are dressing, you can spend about 10-15 minutes asking about what he does usually, how you travel, what are your necessities in your day-to-day living, and what's the job and all that. So with that info, finally you can cook up some sort of a strategy to get this person back to work. So otherwise, it will be a loss nationally. So this will be, I think, this will be described in the next lectures as well. So when you are presented with a wound, now you know you are dealing with a patient with a lot of other issues, and there are so many things that will affect the wound healing. So see this, when you are the problem, the main problem, core problem, the patient came to you is the wound. So the first thing, you should be able to describe a wound. So these are simple things that are taught in the medical school and during the surgical appointment. So you should polish up that knowledge. Should be able to describe the place, size, shape, base, color, depth, edge. What's the edge is doing right now? What sort of drainage? Is it a huge extruded or is there pus and all? So what's the surrounding scene like? Is it inflamed? And any alarming signs? And you should be able to distinguish slough from pus and necrosis. So, and you should have a good knowledge about important structures. Now, everybody has learned anatomy. So that is why I suggest actually wound care is different and dressing changes are different. Unless if you have a good knowledge on structures, the anatomy, and the the physiology, pharmacology, and pathophysiology, you cannot practice wound care. You can do a dressing change. So that's why the wound care I suggest is for doctors. And nurses, of course, if there are nursing practitioners, we don't have that category here. They should go through at least a basic program of anatomy and pathophysiology and all that. So basically, for example, say this wound, if a nurse or whoever who's not very educated cuts off all these structures, what would happen? The human foot is a very complex structure. If you cut even a piece of one tendon or a ligament, it will fall down. The whole balance will go. So I have seen a lot of these things happening. So any counter arguments on that? That is my suggestion. I think wound care should be done by doctors. I mean, there can be so many arguments, but do you have any counter arguments? I would like to have a bit of a discussion on that. Do you agree on me saying that wound care is different to dressing changes?
Yes.
Yeah, I heard 1 year. Yeah.
Yes, yes.
If dressing changes, we can prescribe a dressing and it can be done at home or wherever a nurse or attendant or whoever who's trained to do that the way we want, they can do a dressing change. So, I mean, the whole primary, secondary, tertiary, all the whole package can be done. But wound care is such. That's why I said you have to look into the patient as a whole, the medical, psychology, all those problems. I mean, only doctors are learned on those. So, moving on, chronic wounds, there are so many types of wounds that will be discussed during the wound biology lecture. So, you have to know your basics on types of wounds. You have to identify what type of wound this is. If you put a compression bandage on a ischemic wound, what would happen? You will worsen the ischemia. So if you did not put a compression bandage on venous wound, you will worsen the. Eventually, the wound will progress. Will worsen. There is a pressure. So what is the pressure point? Whether there is osteomyelitis, whether this is something else, whether it's vasculitis. And there's another concept. Whether this wound whether it's healable or we should try maintenance. When should we maintain the wound? This is in palliative care actually. What sort of wounds should we maintain? Is that clear what I'm asking? So which seems is not clear. So, for example, say a 98-year-old fragile old lady coming with dry gangrene of the foot. She has all the, she's bedbound and all the systems are gone. So, in the sense that she's surviving, the foot is dry, other than the pain and few problems. She's otherwise okay. Otherwise, okay in the sense she's frail. She has stroke. Sugars are high. Kidneys are functioning a little bit only. So she just survived. So in that sort of case, since the foot is dry and if it's not shooting in any sepsis, probably, I mean, there's dry gangrene. The option is to maintain and make her comfortable until she passes away. Even if you try, it will not heal with all those. And there are some palliative patients as well. This is also a palliative case that I discussed. Palliative, say cancer palliative patients can't do much just to maintain. So, am I making any sense on that? Did you grasp the idea what I'm trying to say?
Yes.
Say about 69-year-old just had a stroke and in the ICU, she developed a bed sore. She is presented to you with a stage 4 bed sore. can see the gluteal muscles and all that dead necrotic tissue, a lot of dead necrotic tissue, but she is still bedbound with a NG tube and all that. She looks horrendous and ill, but she's just 69 years old, quite well built and all. It's a sudden event. In that case, we should try to heal. That's the idea. She will eventually recover. So this is another concept that we will be discussing in later. So there are so many scientific concepts that come into play when you are practicing scientific wound care. So wound bed preparation goes with this time concept. So this is the application of time concept. So tissue management, the necrotic tissue has been removed, and infection control, drain the pus, open it up, and the most important thing that you will learn and you should remember, is that 90% of wound care is moisture balance. If it's a healable wound, you should practice good moisture balance, it will heal. Provided that the course you found is accurate and correct, and is corrected, the blood supply is accurate, and all the patient-centered concerns in the sense, medical, psychological, social, all those issues are sorted, then moisture balance is the only thing that is needed. So 90% of wound care is moisture balance. Moisture. Is that clear? So from the beginning of this series, I wanted to put this forward. Wound care is moisture balance. So another concept is how to get the epithelium to advance. Epithelium is very fastidious to say. It doesn't go on troughs. Pallam bahinne. It doesn't climb. Be very finely granulated, even surface. Then it will cross. It will cross very fast. Another thing, other than you are trying to get this finely granulated, even surface, you can do something about the epithelium. The edge. You can suture it up. You can try to get it rather closer with some sutures and all that. Those are the things that you can think of doing. So finally, once the wound is granulated, you should converge your efforts into epithelial edge. So for all that, you need a dressing. So dressing selection will be done as a separate lecture. So there are so many things to be discussed in that. So you have to learn about types of dressings, what is an ideal dressing, and most importantly, at the end of this course, at least you should have some rough idea about what is the ideal dressing for this wound. So that is what we are trying to inculcate into you. There are dressings, a lot of dressings. There's an ideal as well, but that ideal dressing is not the ideal dressing for all. You should be able to analyze and find out what is the ideal dressing for this wound. So to find out, you have to ask a few questions. What is the moisture level? What is whether there's infection? Whether it needs debridement? And is there any other function needed like offloading and all? So all that will be discussed in the lecture for resin selection. So resin application, that I think it will be discussed in that lecture as well. There, the dressing has 3 components: primary dressing, secondary dressing, tertiary dressing. So, and a little bit about offloading. That anyway, I will discuss that as well in the last lecture on wound prevention as well. But offloading is not only for wound prevention, wound healing, for especially the foot wounds and the pressure sores, the bed sores, you need offloading. And how to do it is very important to learn. So we will discuss that as well. And another thing that we have to know is planning the review. So there are a thing called EOD dressings. Can I have an answer to know that I am still online and you all are awake? Do we need I mean, do we advise on should we advise on EOD dressings?
Not for all wounds.
No.
EOD dressings actually most of the time those are detrimental. The epithelium is trying to cross, and each and every dressing you are clearing up the epithelium that is slowly growing in. So anyway, so the planning the review, that also depends
But the problem is this, surgeons are already always asking to do EOD dressing.
Yeah, that Dr. Angapera and Dr. Kitsiri, they can address that in their lectures. So why they are asking and all that. And so anyway, my suggestion is EOD dressings are detrimental. There are instances that we have to use daily dressings to get some slough out, to provide a bit of more moisture and get the slough released, and to put some betadine in, and to get the collagen bonds broken. Sometimes for ischemic wounds, the dry gangrene, we have to get it dry and maintain the dryness until you do a vascular intervention. So the daily dressings are done on those instances, but not EOD dressings. And importantly, what's important is planning the review, that you have to consider how whether the patient is able to come weekly or 4-day, that sort of thing. And the most importantly, whether your dressing can hold, how long the dressing can hold. Like if it's does it go out in 4 days? Is there a lot of oozing? Otherwise it gets macerated. If there are any signs of infection that you have to review on that sort of thing. I'm just telling the idea. It depends on case by case. There's no I mean, a wound EOD dressings, a wound every 4-day dressings, a wound for weekly dressings. There are no such policy. You cannot have such a policy. It depends on the case. Depends on the problems that the patient and the wound is having. So little bit about antibiotics. So as someone correctly mentioned earlier, if there are no systemic infection, you don't need antibiotics. The problem with wounds is it's very easy to now they have already formed a biofilm. Most of the wounds, chronic wounds, contain biofilm. So the biofilm has various phenotypes of bacteria. There are active forms, there are stagnant forms, there are spores. So when they are presented with a minute amount of anyway the biofilm will get minute amounts of antibiotics if you swallow a pill or if you give even a IV antibiotics, because they are well protected. So they can produce a plasmid and exchange. So that's the problem with using antibiotics in chronic wounds. And there are few doctors even I know. One I heard from Amuldani area, and there's another one in Yakkala. They use antibiotics directly onto the wound. I pointed those two areas because I'm really against this practice, because I don't think after Alin, linezolid, we got any antibiotics. Am I correct? Can someone enlighten me on that? Did we get any new antibiotics after linezolid? Linezolid was produced in 2015, I guess. Did they give us any new antibiotics? Probably not. As far as I know, then linezolid was the last one to come. So even for that, in about a year, the bacteria developed intermediate level resistance. So imagine if we put antibiotics onto the wounds, and if we distribute this, eventually there will be resistance anyway. If we distribute all this resistance into the sewage canals and all that, so when you put it into the wound, it will go everywhere, and with the dressing changes, it will go to the sewers and all that. So all the antibiotics will be resistant to all the bugs. All the bugs will be resistant to all the antibiotics. So what are we going to give to our children? So that will be a mass extinction level event. So those people who put antibiotics are the culprits. Am I correct? They are actually weapons of mass destruction. Do one of you all put antibiotics onto the wound?
No.
Local antibiotics?
Yeah, someone is talking. Yeah.
The local creams, antibiotic creams can use.
Better not. But those contain a little bit minute amounts. But say even Metrogel gel, this metronidazole part is doing nothing now. Fusidine, mupirocin, and all that. Probably for a surgical wound to prevent infection, maybe so. But I think we should not be using those. There are quite a few indications to put irrigate and put antibiotics. Say in say orthopedic surgery, they use beads, chronic bone infections, osteomyelitis, to save prosthetic implants and all that. There are few. And for odor control, we use metronidazole sometimes in palliative care as well. But still, as far as I know, no resistance has been identified for metronidazole. Correct me if I'm wrong. Anyway, those practices should be avoided as much as possible. But definitely not meropenem, linezolid, piptas. Those IV drugs should not be poured into the wound and washed. That is all rubbish practices. So anyway, when you are using antibiotics also, you should know the local sensitivity pattern and go with it and escalate according to the local antibiotic ladder. So you should know the sensitivity pattern. Usually it's in par with the sensitivity pattern of most of the cases in the local hospital, because it's distributed in the sewers. Is that clear? Am I making any sense? Somebody's mic is on. Can please mute it? Yeah. So moving on to wound prevention, that will also be covered in another lecture. So we have to know bedsore prevention, skin care, stomach care, good comorbidity control, hydration, nutrition, all that goes into wound prevention, and foot care and footwear for diabetic foot wounds. And bedsore prevention, you should know the pressure points. And the final stage of this discussion is about when to refer. So you will get a lot of theoretical knowledge during this course. And one thing, why I put this early on, is that you should not forget it, and you should understand during the course why we should be referring at these points. So there are no distal pulse. You should refer. There's weak pulse equals no pulse. And there are no dressing and see in ischemic wounds. If the foot is ischemic, and if there's even a tiny wound, the days are numbered. You are counting by minute. You should immediately refer. Otherwise, there will be a limb loss. So dry gangrene, of course, similar. And sepsis, systemic sepsis, should refer. And if you are in a hospital setup, admit and manage. Pus, same thing. If you have facilities, you can clean it up, or admit or refer. There's excessive bleeding. What should you do if you cut an artery or whatever? Just like ABC, pressure, ask for help, and all that. Say if you are managing a cancer wound, there's excessive bleeding. Same principles are applied. If it's say an oral cancer, neck wound going into the carotids, the carotids are bleeding, that will be a terminal event. That is terminal care. You have to know how to manage that situation. And most importantly, if the wound is spreading, that means your causality is not right. You have to go back to the drawing board, reassess and find the correct cause and do it, or otherwise refer. There is always somebody who can do it better than us. And when we get into some sort of when we try to repeatedly sort something out with only with ourselves, we are stuck in a frame or a box. So it's always better to get someone else involved so that we break that barrier. So if other medical conditions are escalating, we should get other people involved or refer. And most importantly, again, if there are no progress, either you have to go back to your initial discussion about the cause, or if the same answers come to your mind, get someone else involved. Is that clear? These endpoints are very important.
Yes, sir. Clear.
Because nobody refers if it's spreading. They try various other things and try. And ultimately, the patient comes to someone else. He should go to someone else. And there's no progression. Anyway, if there's no progression, it's good for the pocket. So just do a dressing change and send him off. So we have to try our level best to get the wounds healed in 6 weeks. If the wound is closing up, it's okay to go beyond 6 weeks, but the cutoff should be 6 weeks. So again, what we discussed in the beginning. So most of you all, even in the beginning, you answered well. So about the home dressings, are they good or bad? Any idea? Most of the participants are sleeping, is it?
It depends on the person who is doing the dressing. If it is like acceptable type of dressing, yes. But if it is done in a very contaminated area with a very low ampute area, I think home dressings are bad. But if it is acceptable environment, yes, it's good.
Yeah, agreed.
And
But rather than that, it depends on the condition of the wound, whether you want to revive it. There are any other problem? There are no other problems. You find properly granulating. You just need a dressing change. Can happen at home, no problem at all. Mostly the acute wounds and even the granulating and epithelializing chronic wounds as well. So if you can get somebody trained, even the patient, if they can do a clean dressing change, that is okay. So a lot of traveling and joblessness and all those problems are gone. But it's very bad for the pocket though. Anyway, so that's I think we are at 10:59. So the session should end at 11. So that's the end of the discussion. So from 9 to 11, this is a very probably you all worked the whole day and just joined this conversation. So this was a good discussion. I would have appreciated if more people responded. But anyway, so that's the end of the discussion. Are there any questions, any burning questions right now? I think time's up, but I'm okay to spend even half an hour. Are there any questions?
Any definition for chronic wounds? Any specific time duration to any cutoff time duration?
Doesn't heal after 3 weeks?
3 weeks.
Yeah.
Okay.
I mean,
Okay.
4 weeks. Some people say 4 weeks.
Okay.
Any other questions?
What is the best way for washing wounds? Using water, tap water, saline?
Why should you wash the wound?
To remove the biofilm?
You cannot remove the biofilm with water. That's an archaic
with normal
management for that the people ask them to wash and all.
So anyway, I hope you all understood what Thusitha talks about. Anyway, I anyway, actually now I saw from the beginning there were some problems of joining. Actually, we have enough experiences where if it is a paid workshop, there are people who are trying to get in without payments because they just share the Zoom link, and that is why we were really strict to safeguard the people who has paid and who really wanted to join. So that is why we were really strict about the registration number. Actually, now for the first time, maybe it's difficult and there was a little struggle. And I'm sure next time you all will very smoothly log in. And again, I will put 30 minutes before the sessions, then you all can smoothly log in. Actually, we will give all the instructions again in the WhatsApp our group, and please follow the instructions carefully and please join. And don't worry if you have missed something, the recordings will be posted, so don't worry about that. And you all can chat, and I very generally ask you all, don't put unnecessary things in the WhatsApp group. We will maintain as academic group. And if there is anything related to our practice and academia, then we can, you all are most welcome to discuss and, discuss and get the expertise, get the knowledge uplifted, but don't use that platform to do unnecessary things like good morning, goodbye, all these things and unnecessary things. We all are academics and we will maintain that group as academic group. So Thusitha is again back. So is there anything to ask Dr. Thusitha? You all can ask. And I think Thusitha has to answer one question. He asked the definition of the chronic wound, no? Please.
Didn't they? No, I answered. 3 weeks.
You are just disappearing and coming back.
Now
we can hear. Please.
Yeah. No, I think I answered and someone else replied back as well.
But we didn't hear. Okay, never mind. Please.
Are there any other questions?
You need to complete that question. The washing, the wound.
Washing. Yeah, washing. Yeah. That's where I broke off. No. Yeah, washing. The problem with washing is I don't advise that. I know most of the clinics practice that. Sri Lankan tap water contains Pseudomonas, and you don't need to wash. Why should you wash the wound? What's the point in washing the wound?
To remove odor and some more discharges.
So just mop it off. No.
Contaminated soil, sands, or debris.
Yeah. That's of course if it's a acute contaminated wound, yes. Chronic wounds, what's the point in washing? And biofilm, I heard someone said biofilm, to remove biofilm. You cannot remove biofilm from washing.
With saline, we usually do saline washing.
Yeah, saline washing, I mean, just you clean it with saline. That is not washing, no. Washing is just you pour the whole lot and wash. Why should you waste a lot of saline to wash a wound that is already colonized? And trying to wash and all, it's not like a cloth, no. If you rub everything and try to wash it off, then the epithelial cells will also go.
But now in theaters, the new trend is less use of povidone iodine and surgical and more use of saline cleaning. New trend. I don't know whether it is correct or wrong.
No, if you take it to the theater, that means there is something to do, no? In the sense, say, there is some necrotic tissue or pus or whatever to be removed. Otherwise, it should the thing happen in the OPD, no, the dressing. So if you take it to a theater, that's a different issue. Then you have to decontaminate, you have to dilute the infection. Anyway, you have to then you have to wash. Saline is good. Even distilled water is okay. But what I'm emphasizing here is the OPD setup. In that, you don't need to wash, especially not with tap water. You just have to mop the chronic wounds, granulating chronic wounds. You just have to mop with a little bit of saline, no distilled water. Saline is expensive.
There's another question. On the topic of wound dressing, are there any benefits for the open dressing? Open, just apply cream without dressing?
Yeah, to
in
answer that question.
Setup, the many patients asking without
what?
The patient asking, normally the patient worried to cover the wound.
So that's why, I mean, don't take it in a bad this thing. I will answer you with an example. Say, why should there be a skin? What is the main function of the skin? To cover, no?
Oh, cover.
If there's a break in the skin, let it heal. You have to cover. Moisture. Will there be moisture? What is why I said 90% of wound care is moisture? Will there be moisture if you leave it open? You have to convince that patient. This is what should happen. This is what should. Otherwise, it will just form a scab. It will never heal. It will dry necrotic tissue.
Okay, thank you.
Any other questions?
How about adding gentamicin while doing wound toilets and wound dressing? Is it okay or is it another way of doing malpractice?
With what sort of wounds?
In contaminated wounds, especially involving joints, adding gentamicin while with the dressing with
that has to be sorted out with the orthopods actually. That is a different, I mean, say joints and all. That those are not chronic wounds, no. Gentamicin can be used topically to joints and bones. They do it, but there is a way of doing it. It depends on the current literature. So that we have to ask the orthopods. I can ask. Yeah.
To prevent soft tissue spreading, is it a good practice or a malpractice? Without
Can't say in the orthopedic sense, you can't say whether it's a practice or malpractice. I don't have I don't have enough data right now to say so. If I mean I know they use it, I think that is according to their current literature and evidence. There is evidence can be used. But are you asking for chronic wounds?
Yeah, infected wound with soft tissue spreading.
No, how can it prevent if you are putting it and washing it off? How can it prevent?
Okay, thank you. Got the point.
It's like brushing your teeth and washing with the toilet bowl water.
I have a question.
Yeah.
In general practice, most GPs usually use povidone resin for close the wound.
Yeah.
In case of, is it a good practice or?
No, providone iodine, the thing is when it touches.
And sometimes when betadine is allergic, and povidone
no,
is allergic,
can't hear,
we used to use some antibiotic like sopramycin, fusidico, silver sulfadazine. Is that okay?
Yeah. Yeah, silver sulfadazine is not antibiotic. No, it's a antiseptic cream. It's okay to use. Antibiotic creams contain, but the thing is now whatever what you use, what it does is moisture balance. Say silver sulfadazine also maintains moisture when it incorporates into the primary dressing, the gauze. Say antibiotic cream also the same. It helps in, I mean, it has a little bit of lipids and all. So it makes a sort of a moist environment. So that is one thing. And about betadine, say providone is initially detrimental. It will kill the epithelium and all that. But when it touches the tissue, it releases this active iodine, and ultimately it's water. So it also provides moisture. That's how the wounds heal when you put betadine dressings. It's basically water. You are putting water.
So
it's not
better
a
for
bad.
dry wounds.
Come again?
So it is better for dry wounds than moist wounds.
No, not for dry wounds. It won't give water. That's not enough. Whatever it's giving is not enough. For acute wounds, that's what it does. When it touches the tissue, it releases this thing and gives, it maintains a little bit of moisture. But it is water in about 3-4 minutes.
Short duration. Okay.
Yeah, so that's why, I mean, EOD betadine dressings, that's the idea behind that. In about 8 hours, 4 to 8 hours, all that is dry because it evaporates. So that's why we need some sort of a good primary dressing to hold the water. Anything else? Did I answer your question? Is it clear?
Yes, you are. Thank you.
So I have 2 questions. One is you're gonna cover special wounds like burn wounds in this course, sir? Management of burns.
Yeah.
You're gonna cover in this lecture series, sir?
Now, this is a basic course. Burn wounds are those are specific wounds, no? So, I mean, the basics are the same. We can talk about it, but I mean, there are nothing much to discuss also about burn wounds, unless for complications. If it's a clean superficial burn, you just apply something simple to maintain moisture and close it off. Review in say about 5-6 days. Should be healed, no? So when then the depth goes down, goes up, only the problems occur. So those algorithms should be discussed by should be covered by actually the plastic surgeons. So they know the current scenario. So simple burn wounds, the same principles apply. So we are not going to go into specific wounds. We can do it in a advanced program that will actually come from the university, the medical faculty Colombo, in January.
That is my second question, sir. There's an advanced course for wound care in near future.
Yes. I mean, we also can, the College of Palliative Medicine also can get into it, but it's happening right now. We are doing, we are in the process of producing one. It's almost done. Probably in January, to be started in January, next January, in the Medical Faculty of Medicine Colombo. Tushan will go into more detail on that in his lecture.
Okay, sir. Thank you.
Any other questions?
I have a final question.
Yeah.
What is the best way to treat for the moisturized dressing for any less expensive and moisturizing?
Less expensive and moisturizing.
Moisturizing.
So adding to add moisture, is it?
Add moisture.
Yeah. Simplest way to add moisture is 8-hourly saline dressings.
So to keep for 2 to 3, 4 days.
Yeah, for that you can use a simple gel, like, I mean, Metrogel. Forget about metronidazole part. That's a simple gel, simple thin gel. There are thick gels as well. There are cheap thick gels that are manufactured in Sri Lanka now. So you can use a thick gel
and little bit of Vaseline goes. So that is a very simple resin. Even thick gel itself, you can keep for about 3 days. And Metrogel and Vaseline goes, you can keep for about 4 days. Can even for 5 days or 1 week with a thick gel. Sri Lankan products are way cheaper than even Metrogel.
Are there any name in Sri Lankan
Sorry?
products? Are there any names Sri Lankan products?
I would rather not.
Right. Okay.
Okay.
Because Metrogel is expensive. I think more than 700.
Yeah, I mean, since I mentioned Metrogel, I can tell a name. It's called Fender Gel. Fender Gel and Fender Gel Plus.
Okay. Thank you.
Is there any lecture regarding those things such as intrasite, idasob in this lecture series?
Yes.
No,
Why?
there will be a lecture on resin selection. All those are, I mean, we will not be talking about intrasites or idasobes. We will be talking about broadly on those, what those are, and how to choose what's what. I mean,
But
you're asking about
practically those things very important for us as GPs to know those names to apply for patients. That's why
No,
I
that
asked.
will be discussed. Say if slow release iodine, when we say slow release iodine, we'll be saying example idasob. So we won't be discussing idasob, how to use and all that. That has to be a funded lecture by that particular company. We are not funded by any of the companies, so we are not going to discuss any other products. You get what I mean? But we will be giving you that knowledge. So, I mean, intrasite is nothing else than a thick gel. There are no magic in intrasite. It's not Dhammika Pani, people will say that intrasite had this and that and whatever. Is just a thick gel is water. End of the day, it's water.
So it's better for dry wounds, like to make keep moisture.
It depends. So when you go through the resin selection lecture, you will understand. You have to ask these particular questions, and then you will be given a structure of how to use what, how to choose for dry. I mean, dry in the sense should not be dry because of poor blood circulation. It's not just producing enough moisture to heal itself. So as I said, the wound, the processes are evolved to heal now. So there can be some hiccups in those evolved processes. So that's where we come in, we do a bit of adjustment. So those are the instruments that we do the adjustments with. So intrasites and idasobes came from the West, and now we are in the process of producing those in Sri Lanka. So thick gels, whether it's produced in West or whether it's produced in Sri Lanka, they do the same thing. The West, what is extra in the West is that they will put some pens and pencils and other stuff in your pocket. Is that correct, isn't it?
Yes, sir. We should use generic name, but from generic we don't have.
No, there are no generics in wound products. Those are, I mean, purpose made, no, for them. Say intrasite, they have targeted a lot of dry wounds, and they have added a lot of stuff. And even Sri Lankan products, they have added quite a bit of products. So I mean, there are no generic thick gel. You get what I mean? Each product has its own properties. But end of the day, the main property is adding water and keeping moisture for several days. So that's a thick gel. That is what's going to work, not the hyaluronidases and all that. Those are that is added.
So excuse me, if we apply something like emulsifying ointment, would it help? Or
why do you want to emulsify anything in the?
no, that is as a thick gel. It is cheap.
No, emulsifying ointment that might even work with simple wounds. Might even work, but the thing is, say, emulsifying ointment, if you put to a wound with pseudomonas, they will just draw on it. No, they will break down the lipids and all. The ointments have lipids, no. So you are just feeding them. So that can happen. And there was a product with an emulsifying ointment called Plurogel. Now it's not available in Sri Lanka. It hardly came in also. That had a bit of a property to attack, not attack, to act on biofilm. That's with a lot of other factors involved. Not the emulsifying this thing. So don't put emulsifying ointment for biofilm. Listening to this, it doesn't work. Emulsifying ointment might work for simple wounds.
Yes, sir. Thank you.
Okay, Dr. Thusitha, I think now we have to finish because now only 5 minutes left. Then our Zoom link will be over. But it's quite interesting. And I invite you all to put all the questions on that platform, means WhatsApp platform, and we will definitely answer all these questions. Please make use of that, the WhatsApp platform. And Thusitha, anything to tell?
Yeah, did everyone receive the assignment? What I sent as a document that you can edit and fill in the blanks. That skeleton assignment.
Yes, we did.
Everybody got it, no? So just start thinking about it. Find a case and start filling in. Then actually at the end of the 4 weeks, you can just submit it and get the certificate. Otherwise, you will have to do another week and write-ups and all that. And then now you have the convenience of a group also now. No? You can even bunch up together as groups and discuss. And do your assignment as groups as well. But the report should be individual and the cases should be individual. Is that clear? End of the day, we need a very structured, very formal document that will go into our archives in the college. So that's why we are very particular about this assignment. Okay, otherwise, we can tell just write something and send us, and then we give a certificate.
Okay, then. Thank you so much, Dr. Thusitha, providing this lecture. And thank you, all of you. And I hope if there's anything, please do contact us through this WhatsApp group. And next time, again, like today, next Saturday, we will meet you all. And please try to log in a little early and rename your thing with the number, registered number. Then it will be very smooth. So thank you so much and good night.
Thank you, sir.
Good night,
Good
all.
night.
Thank you, sir.
Thank you, sir.